In this lecture, we're going to be discussing meniscus injuries.
We want you to be able to describe the clinical presentation of a patient with a meniscal injury, differentiate between degenerative and traumatic meniscal injuries, and then determine the presence of meniscal injury based on the patient examination and evaluation, along with the coinciding treatment. When it comes to management of meniscal injuries, there's two broad categories, either non-operative or operative management. And it can be further broken down into four separate categories. The first would be physical therapy management, and that should always be the first recommendation unless the patient has significant impairments associated with it, where their knee is locking up all the time and they can't move it, or something along those lines. The three different surgical interventions that are used would be a meniscectomy, meniscal repair, and a meniscus transplant. We're going to focus most of our time on meniscectomy and meniscal repairs. We aren't going to talk a whole lot on meniscus transplants because it's less common. However, I did attach a post-op protocol there if you want to read more about what rehab would look like after a transplant. For a meniscectomy, that's most commonly performed in older patients with poor tissue quality. This is more commonly going to be associated with degenerative tears. If at all possible, especially in younger populations, we should emphasize the importance of doing a meniscal repair versus a meniscectomy. And the reason for that is because with meniscus repairs, you're maintaining as much of that meniscus as possible. And the more we can maintain within that knee joint, the better for decreasing likelihood of early onset osteoarthritis and making sure that the patient feels comfortable with a lot of different functional activities. In addition to younger patients, surgeons will also be more likely to do a meniscal repair if the tear is repairable and if the tear is within a spot that has better healing potential. What we have seen in recent years is that there's an increased number of repairs being performed versus meniscectomies, and just the increased number of repairs being performed in general compared to previous years. Meniscus transplants is a less common procedure, but it's becoming more of an accepted procedure in recent years. One long-term or longitudinal study, I should say, that looked at the survival rates of meniscus transplants showed that 73% had a survival rate at 10 years and 60% had a survival rate at 15 years. I wouldn't be surprised as techniques continue to improve that those numbers also improve, but as of right now, that's where they're at. And like I said, we're not going to touch on this any further. If you want to learn more about post-op protocols, here's the Sanford rehab protocol that I've attached. For non-operative management, we're going to be taking an impairment-based approach, and we're going to allow irritability to guide the progression of interventions. Management may differ between acute versus degenerative tears, depends on the types of impairments that they're having, in addition to the location of the tear and whether or not that acute tear has the potential to heal. For example, if it's more towards that outer rim of the meniscus where there's better blood flow, that meniscus tear may have a higher likelihood of healing itself, and if that's the case, we should allow healing principles to also guide our decision on how quickly to progress and in which range of motions that we have to be a little more conservative with. I'm not going to get into specifics of that because I believe that's beyond entry level. If you want to learn more about it, you can come and ask me for some articles on it. In addition to that, we should also be focusing on psychological status because meniscus involvement can be associated with some fear, some catastrophization, in addition to some other mental health problems. For example, if you're a young athlete and you're missing your sport because of this meniscus tear, that can weigh heavily on a young athlete. Post-operative management differs depending on the surgical procedure. It looks a lot different for a meniscectomy versus a meniscus repair. What we find is that current rehab protocols have significant variability within them, especially for meniscus repairs and meniscus replacements. One thing that's encouraging to me is that current rehab concepts seem to follow best available evidence, and that was proven by this study in 2020 where they were looking at whether or not the standards for rehab were up to date. Post-meniscectomy management is quite rapid in comparison to other post-operative protocols. In fact, most of the time, patients will return to previous level of activity around the 4-week mark. I've seen as soon as 1 week after post-meniscectomy, patients returning back to competitive sports. The specific example I can think of is there was a kid from a small school that made the state tournament for basketball, had surgery early in the week, and ended up playing later on, I believe it was a Thursday actually. So had surgery Monday, returned on a Thursday to play in a state basketball tournament. Most of the time it's not that quick. However, we'll see patients return much quicker than you would, say, post meniscus repair or post ACL reconstruction. The reason for that is because after they go in and clip everything out and clean everything up, we don't necessarily need to allow for anything to heal. Instead, we just get back to our activities based on how the patient responds from a pain management standpoint, a swelling standpoint, and a functional standpoint. This study from 2013 also showed that patients who do go through physical therapy after meniscectomy have superior outcomes to those who do not do physical therapy. So I believe we should advocate this whenever we get the chance in our communication with the surgeons or the surgeons team. It's typically safe to return to sport once the athlete meets all the requirements for functional testing. So that test battery that we would expect patients to complete prior to returning to sport, it remains the same here. If the patient went through a meniscectomy and they're planning to return to sport, we would expect that they're able to perform their functional tests such as hop testing and have limb symmetry side to side, at least 90% or greater. We would expect their isokinetic testing to be 90% or greater of the contralateral limb. We'd expect that their psychological readiness is up to par. So the same return to sport criteria remains here for a meniscectomy. Most of the time, meniscectomies are going to be performed on the non-athletic population and more the elderly population with degenerative tears. And for those, they're allowed to return to normal activities once symptoms allow. If we're seeing that the patient also has ongoing swelling with increased activity, then we might need to tone it back a little bit. But most of the time, we're going to allow symptoms to guide that process. Conversely, post-meniscus repair management is very conservative early on, and then it's followed by a relatively rapid progression and return to activity after that. A few of the basic principles that you'll follow post-meniscus repair include early passive and active knee range of motion as one of the emphases. Early progressive weight bearing is also important. It's typically a stepwise progression of weight bearing to reach full weight bearing by about 6 to 8 weeks. Typically, patients will be locked in extension for 4 weeks, and the reason for that is because they want that even pressure through the meniscus when there's weight bearing to optimize healing. That's also what I mean by being very conservative right away. That's more conservative than after ACL reconstruction, and that's why if there's a combined ACL reconstruction with a meniscus repair, it's early on that the meniscus repair actually slows the rate of progress, and then later on the ACL kind of takes over that role in slowing down the progress. The last main principle here would be doing a progressive return to activity. What we see is that patients who go through supervised rehab versus those who only do a home program is that those who are going through a supervised rehab program demonstrate higher jump height and greater hop differences. However, there's been no difference seen in outcome measures. So patients typically feel like they're doing well if they only do a home program, but when it comes to functional tests, it's improved if they go through a supervised rehab protocol. And what we know on risk factors for recurring injuries is that if we don't accomplish all of these successful outcomes with our return to sport testing, our functional tests, is that will increase the likelihood of these re-injuries. So it's important that we improve each of these, and that's why supervised rehab should be a priority following meniscus repair. Now we're going to look at a rehab protocol for post-meniscus repair. I don't need you to remember all the specifics here. It's more so just to give you a reference and some ideas of specific interventions or specific goals we should be looking to achieve for these different phases. This is a Sanford rehab protocol. Most of them are relatively similar, but there's going to be some differences between protocols. So again, I would emphasize the importance of you using whatever your facility uses, in addition to your clinical instructors or your colleagues wherever you end up working. For phase 1, that's typically week 0 to 2. You're mostly going to be focusing on pain and swelling control. If the patient does have quad inhibition, you may consider using NMES to induce that quad activation. One exercise you may consider using is straight leg raises in all 4 directions. The range of motion goal here is to get to full extension and 90 degrees of flexion. Phase 2 is weeks 3 to 6, and we're going to progress the range of motion from 0 to 120 degrees. We want to accomplish full weight bearing at 6 weeks in addition to unlocking the brace at 4 weeks. It's about 0 to 90 degrees unlocked from 4 weeks to 6 weeks. Open kinetic chain exercises from 90 to 0 degrees at this phase. You're not going to be introducing too much resistance here. And then proprioceptive training such as a Bosu ball or a rocker board. The thing you want to avoid yet is any twisting or pivoting movements. We don't want to risk re-injuring that meniscus. Phase 3 is week 6 to 9. Here you want to achieve full range of motion while adding resistance to open chain exercises and along with progressing closed chain exercises. At this point, we should also see a normalized gait pattern. If the patient does not have a normalized gait pattern here, that should be our priority. Phase 4 is weeks 9 to 12. Here we want to continue progressing all the exercises we've already been doing. And one of the goals that we should be achieving here is continuing to work towards symmetry, so 80% quad strength compared to the contralateral limb. Phase 5 is the return to sport phase, months 3 to 6. There's quite a range there. Some patients at this point are feeling really good and begin to progress rapidly, where others it might take a little bit longer. And you just have to take each patient individually and help them achieve the functional goals that they need in order to return to their activities they want to get back to. Here is also where you're going to do the first round of functional testing, and then after you go through this return to sport progression, functional test them again, and once they achieve the outcomes you're hoping for, that's when they're safe to return to sport. If they're not returning to sport, just making sure that they're able to feel comfortable and confident and demonstrate their ability to perform every activity they want to be able to do without any difficulty, that's when they can return to those activities. Here's a handful of review questions that you may consider asking yourself and thinking through right now. I think it summarizes a lot of what we discussed pretty well. If you have any questions, please let me know.